If I start a patient first line targeted agent, and I see there's only two reasons why I would stop first line treatment and why it's unsuccessful. Number one, if they're really not able to tolerate the medication. If the side effects, despite aggressive management, dose withheld, and dose reduction, they're not able to tolerate it, I would stop the therapy and deem it unsuccessful. The second reason why I would stop therapy in the first line setting is because of progression of disease. So when I started therapy, I would typically repeat imaging every 3 months to monitor the response to treatment. And if I see that the tumor is getting bigger, or if there are new tumors that's popping up, then I would deem it unsuccessful and change to a second-line therapy. Options for the second-line therapy for patients that progress during first-line therapy or can't tolerate first-line would be another targeted agent. So there's about 6 to 7 targeted agents approved for kidney cancer. I would move on to the next targeted agent. If they had Votrient, I would do Sutent. Cabozantinib would be another great second-line drug. Nivolumab, which is a completely different mechanism than the targeted agent. It's an infusion immunotherapy through the IV, is another good option as second-line treatment. Another class of agents are the MTOR inhibitors. There's temsirolimus, which is an IV, and everolimus, which is an oral, that is a potential option. However, in the second and third line setting, I definitely do consider patients for a clinical trial whenever possible. The quality of life factors most importantly in my decision making when I recommend a treatment option, because these treatments are not benign. They do have their side effects. So if I see a patient and I know that they're going to struggle with a medication, and if it's going to be a class effect and the side effects are pretty much generally the same, I tend to go to another class, like the immunotherapy in the first or second line setting. Generally, immunotherapy, they do have their own side effects, but the side effects are different from the targeted agents, and they're much more tolerable. I have given immunotherapy to 80, 90-year-olds, and they do pretty good. So if the side effect profile really interferes with their quality of life, I generally tend to take that into consideration and recommend an alternative therapy. There are other factors that I consider. We haven't talked about different types of kidney cancers. The most common type is clear cell, which makes up about 75 to 80%. There are non-clear cell renal cell carcinoma that they don't have a good clear standard of care, and we treat them as clear cell because really there's not a lot of good options for non-clear cell. So if I see a patient that has non-clear cell like papillary or chromophobe or collecting duct, I treat them completely differently sometimes. I definitely consider them for a clinical trial, and if they don't have any other options, I basically treat them like a clear cell.